Hello, everyone. This is Lisa Myers with ARX Healthcare in Franklin, Tennessee. On behalf of the Tennessee HFMA chapter, I would like to thank all of you for participating in the webinar today. Just have a few announcements to go through before I announce our speakers. We have posted the slides on our website. You can find those in the link in the GoToWebinar chat box below on your screen. Registration will be open shortly for our next webinar, Financial Engagement Strategies for the New Healthcare Consumer, How Retailization is Shaping Revenue Cycle. That will be on August 9th. You can visit tnhfma.org/webinars for more information. If you would, please save the date for our Fall Institute, which is scheduled for October 19th through the 21st in beautiful Gatlinburg, Tennessee. We have a great lineup of speakers and topics that you will not want to miss, and more details will be available soon. Requirements to obtain CPA certificate for today. You must be connected to the webinar for at least 90% of the duration, and you must respond to at least 2/3 of the polling questions when those come through today. Our speakers are Micky Allen and Margaret Govelitz. Micky is a client success manager at Craneware and works with health systems to help them achieve their financial goals. He is the former Director of Revenue Integrity for UMC Health System in Lubbock, Texas. Micky brings 14 years of healthcare experience in several roles throughout the revenue cycle. These include EHR implementation, charge master coordination, and HIPAA X12 EDI implementation. His main focus has been creating defensible pricing strategies, ensuring accurate and complete charge capture, and directing collaborative initiatives among revenue-generating departments to achieve revenue integrity and compliance. Micky holds a degree in clinical laboratory science and an MBA with a healthcare IT concentration. Margaret is a revenue integrity manager at St. Joseph's Candler Health System in Savannah, Georgia. The St. Joseph's Candler facilities have been using the Charge Master Toolkit for the past 6 months. Margaret has over 22 years experience in the revenue cycle arena, including charge master coordination, procedure and supply pricing, and denial management. Her other healthcare business experiences include being a business manager for surgical services, cath and electrophysiology labs, and she has also been a financial coordinator for various nursing units. Margaret brings a unique blend of hospital business and clinical understanding to the facilities she has worked at. Margaret has an AB in biology and an MBA in finance. And at this point, I'm going to turn everything over to Micky and Allen. Micky and Margaret, excuse me.
Thank you, Lisa. Okay, so good morning to some folks and good afternoon to others. Let's start, by going through the agenda of the 3 areas that we're going to discuss today in the presentation. First of all, we're going to start with defining revenue integrity and then identifying the need. And then the second section will be managing the revenue integrity operations. And then third and last will be conducting and sustaining the revenue integrity improvement initiatives. Before we start the actual presentation, let's talk about how change is driving innovation. We have an evolving healthcare marketplace that's shifting to new financial performance metrics, with the focus being on value. So we're kind of going from this revenue cycle management moving into the value cycle management. And of course, in the past, we've seen mainly, capitation and fee-for-service, with currently kind of having a mix of fee-for-service and that value-based, and moving, of course, over to population health. And I'll move into the next slide and kind of explain this a little bit more. With this movement, we're moving away from the standard revenue cycle model of fee-for-service to the value cycle, looking at value-based reimbursement and those operational impacts to drive to cost, quality, and outcome. And this allows delivery of the best care at the lowest cost. And this new paradigm of success is focused on the right patient, the right place, the right diagnosis, and the right treatment. And when done at the appropriate setting and cost, the patient outcomes are optimized, as well as the financial outcome for the provider. As it says here on this slide, the value cycle is the process and the culture by which healthcare providers pursue quality patient outcomes and optimal financial performance through the management of clinical, operational, and financial assets. We'll now move into the first section, defining revenue integrity and identifying the need. for defining revenue integrity. Now, revenue integrity can be a standalone department, and that's where my background comes into this presentation. It can be an initiative or, a change in the organizational structure, and that's where Margaret's background comes into the presentation. And of course, the primary objective here is to prevent the reoccurrence of issues that cause revenue leakage and or compliance risks. And the focus is the process improvement across all areas of the revenue cycle or value cycle, as we just discussed. And then, of course, support from administrative leadership is essential in this process, and the use of technology is critical for maximum success. So now, moving along with defining, or continuing with defining revenue integrity, you need an action plan. So we must have alignment between the revenue cycle objectives and the organizational strategy. And by this, we need to decide if we're going to establish a revenue integrity department or if it's going to be an initiative or an org structure change. And then, of course, we need to assess those revenue cycle policies for existence first, and then, review them for completeness and accuracy as we move along this action plan. And then define a revenue cycle roadmap, for your action plan as you move forward, in the coming months or years in the future. So we need a proactive and integrated and automated charge master management. The performance improvement focus especially on charge capture, and we need continuous monitoring with business intelligence as a best practice recommendation. And this allows us, to have charge reconciliation reports that can be pushed out to clinicians, key performance indicators that can be defined, and dashboards can be created for performance metrics. We need identification and correction of those processes and systems leading to those lost revenue opportunities or compliance issues. And then we need dedicated oversight to ensure that chargeable procedure, item, or service is documented, captured, coded, billed, and of course ultimately paid accurately. Now, continuing on with identifying the need, we'll look at that with my background as a revenue integrity at UMC prior to my joining Craneware. My experience in the EMR implementations demonstrated the need and the opportunity to improve revenue performance. This was primarily recognized first within the emergency department, because that's where, of course, we started with our electronic medical record implementations. We process mapped all those emergency department processes, and then by doing so realized that it was difficult to identify accountability for revenue, I say house-wide here, but also in the emergency room and with the interaction with the emergency center. House-wide, we could see that same theme spread throughout. And of course, for the clinical staff, complete and accurate documentation and charge capture will always be secondary, importance to patient care and patient safety. And of course, by reviewing that, we recognize opportunities to positively impact several areas. We saw that, there's areas to improve on incomplete documentation during the charge capture reconciliation process. We found that there were a lot of missed charges and late charges, mostly missed charges because late charges are easily identified, if you're paying attention to those charges hitting on the patient's account. And then, of course, areas where we can resolve the root cause of denials, and then improved overall performance due to the incomplete charge capture. And of course, by developing a revenue integrity department or initiative, an organization will be able to implement and manage revenue cycle improvement initiatives, across the health system and clinical departments, which ultimately results in improved compliance and increased revenue, both of which, of course, are good things for the organization. Continuing on within identifying the need, we'll talk about getting buy-in. We need to secure administrative approval, of course, for the revenue integrity program. And to do so, a business case for the revenue integrity department or initiative needs to be developed. So whether it's a department or initiative, we really need a business manager, for oversight of all the revenue generating departments for it to be, to maximize the effectiveness of this process. And of course, that person would need to be responsible for the CDM maintenance and internal charge audit functions, with the focus, of course, on improving net revenue while ensuring compliance. And a very important piece is removing those silos and getting all the areas of the revenue cycle communicating and cooperating toward the action plan that's been defined. And then we want to prepare to start in the areas with the greatest potential for charge capture improvements and provide preliminary findings back to administration to help support the action plan that you plan to put in place. Of course, myself and my background started in the emergency center because that's a very complex department, moving very fast, and of course it interacts with all or most areas of the hospital, so you get insight to all that interaction and areas where where you can improve outside of the emergency center very quickly. And of course the cath lab, an area with high dollar reimbursement, and of course other complex areas like the pharmacy or surgery. And of course, your facility may have other areas where you have known concerns, that you can be put in as part of that action plan and start there as well. So with that, I'm going to hand it over to Margaret where she can pick up and talk about her background.
Thanks, Mickey. This is Margaret. I just want to let you know a little bit about how I came to St. Joseph's Candler. It was about 2 years ago, and I came from an HBO shop moving into a Meditech shop that just so happened to be going through an major implementation process, going from Magic to 6.13. As I said, I did not have any experience in Meditech, but then again, this integration was just so big, none of the clinical departments did either. So basically what I had was a crash course in Meditech 6.13, and then I was able to go out and disseminate this information into the clinical areas, thereby establishing my relationships with them and able to getting them to have buy-in into the revenue integrity portion that I was manager of just recently. What we need to do is we're looking at identifying the needs and our objectives. We want to be sure that we can improve our charge practices at the department level. We want to provide resources for maintaining those charge accuracy, and we also want to educate on charge compliance and denial issues. We need to understand, in order to do this, we need to understand the current situation. And when I came on board, I spent a lot of time understanding how departments worked and actually going out and visiting departments and making sure that we all were on the same page and I understood what they were doing. What we wanted to do too is to improve on that. So what I would do after I went and met with the departments and had some experience under my belt, got them up and running on 613, I would bring them over into my office and we would have a discussion on their charge practices and build on those relationships. We used ourselves, the clinical departments and myself, as mutual resources between revenue integrity and clinical. And we also did some education, filling in the gaps for each other. We're now ready for our first polling question. Next slide.
All right, so our first question today is, does your organization have a revenue integrity department or initiative in place today? We have a dedicated revenue integrity department. No department, but we have revenue integrity initiatives. No, but we are in the process of getting started. No, but we would like to in the future. Other or not applicable. And just as a reminder, for anyone obtaining CPA certificate today, you must respond to at least 2/3 of the polling questions. We have about 85% who have voted, so I'll give it a few more minutes. Give everyone a chance to answer the question. All right, we are going to close that question. And Margaret and Mickey, in case you are not able to see the answers, 62% have a dedicated revenue integrity department. About 16 do not have a department but have revenue integrity initiatives. There's about 3% that do not but are in the process of getting started, 5 that do not but would like to in the future, and 14% other or not applicable.
Okay, we're ready to move on. Our next section is talking about managing revenue integrity operations. And what we wanted to look at here, next slide please, we want to look at how you do a staff and structure. And basically, we'll probably need to make a business case, although I'm sure most CFOs would understand that revenue integrity and charge capture and revenue capture, given the state of healthcare revenues at this point in time, is very important. And I think that that being able to make that case would probably just help you in focusing on improving net revenue or picking up any money that's being left on the table. And also in our regulatory environment, making sure that we're also compliant as we're doing this. One of our staffing examples that we can demonstrate for you today is looking at a 4-member team at a single teaching facility. This is basically how Mickey had his structured, with the Director of Revenue Integrity who oversees the development, coordination, implementation of the revenue integrity efforts, a CDM specialist who oversees all aspects of charge creation, a RAC audit coordinator who oversees the coordination of all external audits for both government and commercial payers, and coordinating with necessary departments to mitigate the risk. And also an internal charge auditor who coordinates monthly charge audits, working closely with the CDM specialists and clinical areas to improve the efficiency and effectiveness of charge capture and compliance. Next slide, please. The example of an organizational structure reflecting this would be having a revenue cycle VP, and then the reports from that to that revenue cycle VP would be a Director of Patient Access, Director of Financial Assistance Office, Director of HIM, Director of PFS, and a Director of Revenue Integrity. And beneath that, you can see the 2 functions, the Charge Master Specialist and the Audit Coordinators. Next slide, please. At St. Joseph Candler, we use a little bit different approach. Revenue integrity is built into the Director of Patient Accounts, who reports to the CFO. Under the Director of Patient Accounts, you have a denial manager, a patient accounts manager, a pre-service manager, registration manager. And again, under revenue integrity manager, there's a revenue integrity analyst who monitors charge rejection reports, assists with CDM review, performs departmental charge audits, and resolves billing edits. There's also a charge auditor who reviews late charges and reaches out to the offending departments, who reviews this charge interface daily for big gross errors, and also assists with supply and implant price to cost information for CDM maintenance. Next slide, please. Additionally, at St. Joseph Candler, we have a monthly revenue cycle roundtable, which includes all of the managers under patient accounts, along with their director, also the controller, the decision support manager. There's a clinical represented. IT is there. The RAC audit coordinator and compliance director, HIM director, are all there to discuss monthly issues. Recently, some of the issues that we came across was, of course, the JW modifier, which has been tabled to January. And this is an interesting because it brings out the revenue impact of that of applying that JW modifier. It also makes IT aware that there's going to have to be some work in our IT system and in our hospital billing system to be able to accommodate the JW modifier and actually have it be brought out either in a billing edit or as an account check in order for us to work those codes to be sure we've got our JW modifier in the correct data set. We also look at high-level RAC and denial audit issues and bring that forward to revenue integrity if they aren't aware already, and also to the other areas, letting us know what revenue impact those are having on us. IT is there also for implementation issues, and we're undergoing another upgrade from Meditech 613 to Meditech 615, and at this monthly meeting, we have a monthly update on testing, how we're doing testing, and as it impacts revenue cycle. Next slide, please. Now we're going to talk a little bit about managing resources and monitoring. Our resources at St. Joseph Candler include the compliance office, internal audits, and department directors. And each of these revenue cycle stakeholders has a dotted line responsibility to each other. So as a revenue integrity manager, I'm constantly reaching out to the compliance office and internal audit to bring forward issues that I'm seeing and asking for their advice and input. Likewise, they reach out to me, and we have a constant dialogue going back and forth. I found also that in my experience at St. Joseph Candler and elsewhere that the revenue cycle and the revenue integrity manager CDM manager has a lot of contact with the clinical departments, and understanding that that we bridge each other's experience and knowledge. I'm able to bring to them an explanation of the business cycle. They're able to bring to me their explanation of the clinical cycle. So we are able to interpret CPT and HCPCS codes as we work together. Next slide, please. Additionally, managing the revenue cycle requires involving the clinicians, and even beyond the clinical leaders and team leaders, it involves developing a physician champion for specific projects. And they can assist us in gaining physician buy-in and demonstrating importance of initiative. They can champion all other clinicians. They can, we need to present them the big picture up front so that they can champion and spread the goal to other areas. We also do close interaction with non-physician clinicians, and that means attending nurse director council meetings, nurse education meetings, presenting metrics to illustrate revenue cycle impact, emphasizing that if you are able to capture those dollars, you're able to increase staffing or at least maintain staffing, and that nurses become engaged and help identify and suggest process improvement opportunities on their own, as well as listening to you for your input on those opportunities. Next slide, please. In order to manage revenue cycle, we need to utilize tools and resources. And through the Revenue Integrity Department, we take a holistic approach, identifying and implementing tools and resources that are instrumental in achieving successes. Our charge master review and maintenance is an ongoing closed-loop process where, as you're developing your charges, you're getting immediate feedback on whether that charge is going to have a compliance issue or if there are other charges allowed to be charged along with that one that you're looking at, and whether or not those are missing from your charge master. It's an active maintenance solution. It's really very fun and fun to work with, I think. There's a charge capture and integrity tool to establish a periodic review cycle for all outpatient claims. This takes place with our auditors and getting a sample of specific issues that we want to take a look at. You can implement a solution that allows custom edits to shift the balance in your favor by compliantly that will help you organize yourself. You can improve charge capture by identifying potentially missed charges and correcting errors at their source to ensure claim accuracy and compliance. And we can also use business intelligence that will be through the KPIs, your key performance indicators, and a revenue cycle dashboard. You can use a clinical subsystem link and usage review for those ancillary departments that feed into your charge master, into your billing system. And you can also push reports out for a complete and accurate charge capture coming from your business, either from your hospital system also. Next slide, please. Also, a role of revenue integrity is looking at new business projects and making sure that when there's a new service or a new item coming in, revenue integrity is actually being a part of that process, where you can add to value analysis for implants, say, or whether you can actually charge for some of the services that a new center wants to provide. So the role of revenue integrity is also to be sure that coding is aware of any changes to, or any additions or changes for charging for that implant, say, or to ensure that compliance is aware of a new service and any potential issues that may be arising from that service or supply implant. Next slide. Some tools that we can use for managing our revenue integrity would include hospital operating system. We can use that for reports or checks. We can utilize the hospital scrubber system for edits. We can also use the websites. We can use our charge master tool. We can do networking. We can do HFMA information. Next slide. I'm now going to turn it over to Mickey, and we'll continue talking about managing an integrated CDM.
Okay, thanks, Margaret. Yeah, and just to kind of expand on this, we've talked about this or touched on this several times throughout the presentation today, the integrated CDM management, of course, developing that closed-loop automated process from CDM initiation to creation of in the billing system. This is an active maintenance solution that allows, immediate resolution of all those issues before the service code is created, to assure that you have the regulatory issues and everything covered for that charge creation. And then the benefits of an automated closed-loop solution, of course, it decreases the incidence of miskeys because you're doing this in one system, and then, of course, you can interface that into your patient accounting system. And it decreases the incidence of non-compliant billing, so the regulations, are built into that tool that helps you, like I said, create that charge code compliantly from the get-go. And then immediately identifying associated items that are missing from the CDM. So this would be CPTs that are possibly linked together or that are linked together that you may be missing from your charge master. And then it allows you to maintain a centralized, easily accessible, of course, audit trail of what changes are being made in your charge master, of course, which feeds over into your patient accounting system. And of course, you want to have good control over that, not have too many hands in the charge master making those changes. Continuing with managing back to the business intelligence as a best practice, we hit on this a bit earlier as well about reviewing your electronic medical record setup. So I think with the best practice too, it's an organization should have an IT analytics team, that's controlling that business intelligence and bringing all those databases together into one data warehouse. Of course, this can be done by other means, but of course, the best practice would be, having business intelligence and a strong IT to help. Would be a huge benefit, of course, to help with this initiative. And of course, for reconciliation, it's very important with, all the electronic medical record systems and clinical systems that are out there, that have linkages for charge capture, and sending that over into the billing, module, or it could be a disparate billing system, that you monitor that for accuracy. Looking back at my past as a Director of Revenue Integrity, we kicked this initiative off once we gained the business intelligence within the IT analytics group, and just one miskey error when someone transposing a number on it, and I believe this was on a radiology, it was sending over a CPT code that was paying less than the correct CPT code would have, which when annualized out, that you can see easily that the benefit there was over $200,000 in net revenue or cash in the bank. And of course, the organization had no reconciliation process in the past, so this recon was, this reconciliation was easily overlooked, and just building these charges in the clinical system, was something that was moved forward with and never really looked back and reconciled. So looking for this charge code and CPT mismatch is a very important piece of that revenue integrity initiative. Continuing on with business intelligence reports that we've talked about earlier, being able to push out reports, to improve that integrity and that compliance. And I threw in a few examples here, just some ideas of business intelligence reports that you can push out, from the system, from the IT analytics group, out to the clinicians or the departments or the clinical, directors or educators or whoever you have actually monitoring that process. And a lot of these as well within the Revenue Integrity Department or whoever's managing that Revenue Integrity Initiative, like a daily charge variant, to catch system issues. This is something where we worked with clinical IT, or you can do so to create reports that are comparing, your daily average charge batches for this week compared to, prior 2 weeks, and looking for either huge drops or huge increases. And the real goal here was to look for those huge drops or to catch, electronic billing from those clinical system, any breakdown where linkages got broken. And we've seen this with upgrades, to the electronic medical record. I can think of a really good example in the past where they did an upgrade to an EKG system and it completely stopped charging, and this report was able to catch that. You didn't catch it immediately, but at least doing a comparison for that 1 week compared back to the few, we caught it quickly instead of letting that continue to go on and losing that revenue. And then another report like electronic charge sheet daily or detail for the previous day, and I have an example of that I'll show you later on, but that's just your daily reconciliation with the charge departments pushed out to those departments via email where they always get that. They know that that's part of their process and that, part of the policies to do that, and much better when you can push that out instead of having them have to go retrieve those reports. Things like very large charges, too many units here. I mean, I know these reports have to be tweaked because you can easily be over 10 units or high dollar, 10,000, but it's department specific. So you're looking for those anomalies in those departments, and that's very helpful in identifying, fat finger errors or where something may be duplicate charging. Looking for if you have exploding components, sometimes those components of an explosion charge get deactivated and those are still being sent out. Looking for those MUI edits, those medically unlikely edits, where if it's greater than one and we shouldn't be billing more than one a day, how can we stop that so that we don't have issues on the back end getting those out? And of course, looking at your daily denials, typically you have someone working denials or having a denial management system, but this was kind of a report, pushing out daily for someone to take a quick glance and see what types of denials are happening that day and do we have a handle on that. That goes out to a larger group so that you can get eyes on that quicker and get input faster there as well instead of your dedicated denial resource. And then with the business intelligence course, building out a revenue cycle dashboard, I think, with the key KPI metrics we talked about and being a performance-driven organization, to monitor that revenue cycle performance, I think is key. And then incorporate benchmarks into those improvement goals and then to make those part of, annual competencies, to push those improvements and of course talk about those in that monthly revenue integrity meeting that Margaret spoke of before, and bringing that back to the group and continuing to monitor and improve. And then of course the truth is in the data, and of course it's your data, so highly recommend of course with business intelligence that you use that data to help you gain insight here and of course monitor that improvement. And I will pass it back to Margaret.
Okay. Our next section is going to talk a little bit about charging via electronic documentation. I've had experience in this in nursing areas where they're documenting and charging off of their documentation, and also in the ED, and also through an ancillary system using an order coming across from an imaging system going over to converting to a charge on the billing system. So it requires discussion and close work with IT to make this all work out very, very well and smoothly. And it also requires clinicians who understand charging, what's allowed and what's not. And what you have to do is remember also to perform a periodic review of your links between documentation and charging, just to be sure things aren't getting broken. As CPT codes and HCPCS codes are changing, you want to be sure that your documentation is going to reflect that. Or if it's an order, you want to be sure your ordering system is actually linked up correctly to your charging system. Be sure everything is all nice and stable and ticked and tied together. I'm going to go back to Mickey for a little bit more on electronic charging.
And here, this was just an example. I was saying earlier that I had an example of a push report of this was a reconciliation, for bedside procedures done in the nursing units, and we were able to push this report out to the units on a daily basis. They would take this and reconcile it against the previous day's patients and visits that came into the department, making sure that they had charges for every patient and were those charges complete and accurate. And then here's an example, of the business intelligence. This is a look at a revenue cycle dashboard. We had, of course, had this across the entire revenue cycle. This is just looking at, AR and our days in AR. Of course, in the lower right-hand corner, we want to try to keep our days in AR down. Looking at that national average, of course, we wanted to keep it underneath that. You can see here we got above, and then, of course, you get initiatives to start bringing that down, because revenue integrity can have, a big impact on that by bringing those departments together. And by process efficiencies, decreasing late charges and things that are holding up claims, making sure that you have complete charge capture, and of course, if you don't have that complete capture and you're adding hold bills, or billing holds, through routines or whatever that case may be, and holding up those claims, which has an effect on days in AR. So, I mean, that's the goal there, is just to not hold up those claims. You want complete charge capture. We do not want those late charges. And now we'll move to polling question number 2.
All right, for our second polling question today, does your organization perform charge integrity audits, and if so, how? Options for answers are: we use charge capture analysis software, we use manual random quality audits using claim samples, we use our denials data, no, we don't currently do this, other, not applicable. And again, just as a reminder for those of you seeking CPA certificate, you must respond to at least 2/3 of the polling questions. So it looks like we've got about 55% that have voted, so we will leave that open to allow everybody time to vote. We've got about 15% that haven't responded, so I'll give you guys another 15, 20 seconds or so to respond to this question before I close the poll. Okay, I'm going to go ahead and close that question and share the results with you all. 32% use charge capture analysis software. About 34% are using manual random quality audits. About 11% use denials data. 6% are not currently doing this, and 18% other or not applicable. Micky and Margaret, I will turn it back over to you.
Thank you, Lisa. Okay, now for the third and last section here for the presentation, conducting and sustaining revenue integrity improvement initiatives, so achievements and successes. So for revenue improvement initiatives, the CDM management, so establish the proactive CDM maintenance, of course engaging the stakeholders from throughout the organization in the process. We want to produce a CDM maintenance policy that defines the accountabilities, task schedules, and performance metrics along with that. And of course, reduce compliance risks, denials, rejections, and return to provider issues in billing so that we're not having to do that additional work on the back end. With integrated CDM management, it's important to mention this again. I keep harping on that, to develop a closed-loop automated process for the CDM initiation to creation in the billing system again. So you get those charge requests entered, via ChargeMaster tool coming from the departments or areas where charges are needed to be added or maintained or monitored. And then that active maintenance solution that allows resolution of all those issues before it's created, identifying those missing associated CDM items, and then that it includes that easily accessible audit trail, and of course it improves billing compliance. Some additional improvement initiatives, the electronic charge sheet. For myself and my background with the nursing, we did our best to transition all of the departments that were using paper charge sheets into the electronic charge system. Of course, your system has to allow that, and it's important, of course, probably having a clinical IT shop to help move forward with this. And it greatly improves the revenue and the process this. So the initiative that we put in place for just the nursing units alone, they were completely on paper, and creating those paper charge sheets, giving them off to a health unit coordinator, handing that went into a courier that was sent over to patient financial services to get entered manually. You can see the breakdown in the process very easily there, that a charge code may not be created. Folks weren't reconciling those. It's got to make it over, and then you've got someone who doesn't have the knowledge of the charge processes and what's going on from clinically entering those charges. And so by doing that electronically, saw as much as 130% increase in gross revenue, not across the hospital, but just in those nursing areas where we implement those electronic charge sheets compared to that paper process, which was, it was huge. The numbers went, from 12 million up to as much as, 30, 35 million on that with that improved process, And then you find that nurses do prefer those paper charge sheets over, because tasks were created instead of having to go find that piece of paper, fill that out, and be sure that they get that done before they leave. And then another area that you can implement, software as well is within the pharmacy to improve that revenue capture and reimbursement. Of course, the pharmacy is a very complex area with those building of charges, but using that, you can improve your charge capture pricing, of course, and your cost management. This can integrate, seamlessly with the CDM software. So if changes need to be made or communicated to the charge master maintenance folks, that can easily be done within the software. And we're ensuring that those medications are accurately billed, priced, and reimbursed. And it identifies revenue opportunities that help create defensible pricing strategy as well. Here, I've just put an example of like a nursing charge sheet. Of course, this is from the Cerner system, but this was an example of how we took that paper charge sheet, put it into an electronic process. The nurse could easily document what she had done, he or she had done, and then there was also a window over on the right-hand side that showed what they had charted to kind of help them guide, hey, you've documented this, let's be sure that we charge for this. And of course, that would feed the charges in. Then you have the business intelligence, which is sending out those recon reports that I showed earlier, that has them reconcile the next day the charges that were submitted on the previous day's patients, and just kind of completes that whole process of the charging and the recon there, all electronically with technology. And then for some revenue improvement initiatives to continue with that, with other innovative ideas, creating a billing holds or system routines, whatever you call them, to try to prevent missing charges or out of compliance charges, working with your patient financial services system and folks there to make sure that you get those created appropriately, and tested and monitored and validated. And then post-processor programming, if possible, to help automate charge entry. For example, you have blood administration can always be billed with blood products. So putting in processes, what we did in the past was put in a routine, of course, that had to be monitored to where it was easier to automatically enter that charge versus someone having to go in and enter those manually. And then, of course, you would still need to monitor that and do reconciliation there. But it did speed up the process, so it was an efficiency gain. And then holding things like microculture and genome testing that takes a long time for the results to come back. So sometimes it can be 4 to 6 weeks for getting those results back. And of course, when I was director there, we were sending those claims out. Those charges weren't coming in because we were waiting on results. And so you could easily miss out on $30,000 to $60,000 in gross charges there. And of course, which of course means money based on, if it's outpatient, of course, if you got percentage charge payers. Charge match monitoring at the department level. This was again looking at those daily charges that went out from the clinical systems over into the financial system, making sure that there was consistency there on those daily averages. And then of course a monthly report of unused and never used charges. The real importance here is the never used charges, is why are we creating charges and never using those. So getting to the bottom of that reconciliation there to make sure that those charges are set up appropriately in the ancillary systems, that folks are aware that they are created and we get those being used, or if for some reason they don't need to be used or they are unused, getting those out of the charge master and cleaning that up. And then a monthly report of whole bills, on previous month's visits, and this is just to get those old visits that are being held corrected and get those billed and out the door, trying to get to the bottom of, why are these being held? What can we do to improve the process and efficiency there to make sure that they get out in a timely manner?
We have some revenue improvement initiatives. We have some revenue improvement initiatives also over at St. Joseph's Candler, where we're using our billing scrubber functions to update HCPCS code for specific payers. This is kind of a homegrown way of getting around to some of the issues that Micky's been talking about, but it definitely is a process that works. The issues come out if they don't meet that edit, they come out on an edit that's worked by one of the folks in revenue integrity. We also have a report that generates missing charges from the billing system. For example, if you have an ED level charge that's missing from an ED account, or if you've got the blood administration charge is missing the blood product charge, or vice versa, or if you have a specific payer requiring specific CPT HCPCS codes to be also placed on that specific payer bill as it goes out. To develop these tools, we used a lot of interaction with the PFS for the billing scrubber edits, and also with IT to provide the reports for the account checks for the to get those claims, to get those edits going before the account hit the billing system. Next slide, please, and back to Mickey.
And this here was just trying to give an example. This is just a character cell screen showing some of the holding bill, just a snippet of those hold bills or system routines that are helping to improve charge capture and prevent those missing charges, or with that compliance, using many combinations here, using CPT codes, using ICD-10 codes, using revenue codes, and those different combinations, to help prevent missing charges as well, like I said, as being out of compliance. And here, getting close to the end here, but talking about, the return on investment and, through the analytics, this process. So I think that is, is key, to following through with the Revenue Integrity Department initiatives. And areas of strength needed here, kind of what I'm getting to here in this list, is daily tracking of those revenue and compliance findings. So as you move through these initiatives in your action plan, be sure you document what you're finding, whether it's a revenue integrity improvement issue or a compliance issue, so that you can track that, calculate, what your return on investment is there, and get that back, to administration, but also back to the clinicians to show, what their involvement and what they've done to help you with these initiatives has done for the organization and the process. And of course, understanding that inpatient versus outpatient reimbursement is very different. So you need someone, of course, in the Revenue Integrity Department, in my opinion, that understands that. Of course, understanding your Medicare and, of course, your state Medicaid program, because the state Medicaids can be very different. And then the managed care contracts, having a good understanding there, because those are, of course, unique to the organization. And with all the differences that can happen within those contracts, whether it's carve-outs or fee schedules or whatever the case may be, especially if you got percentage charge payers, how important those charges are to get on to the patient's account, so that you can get those dollars earned and deserved. Knowledge, of how to query data if you have, that IT background, someone in the department. If not, having those resources. That's where I referred to in the past slides, talking about having an IT analytics group or a strong IT group that can help query that stuff for you. And here was just an example here of the first 4 years of the Revenue Integrity Department at UMC, where I was prior to Craneware. We started that first initiative that first year in the emergency room, so that was strictly honing in on emergency center opportunities. And you can see what the total gross revenue found and what that returned in total net revenue by doing a good ROI analysis on the payer mix in the emergency room and those contracts, and coming down to that net figure, cash in the bank on that first year. And you can see as we moved out of the emergency center in year 2 and went into additional areas of the hospital that were identified by starting in the emergency room, how you can see with more initiatives, more buy-in, more support, by having that positive first year, what the difference made in improving that gross revenue, which in turn improves that net revenue or cash in the bank. Stayed strong year 3. Year 4, we started seeing kind of a decline, and it gradually went down because we have made significant improvements with the process and the department. And so that's, kind of what you want to see. But it's eye-opening when you really have that strength in that analytic process to really come back and show that to administration, take that back, the individual components to your departments, and say, hey, here, these initiatives where I know it was kind of a thorn in your side to help us get some of this stuff going and moving forward, but here's what the difference that it made, and of course that's improvement in FTEs, that gets you new equipment that you didn't have or that you need, supports those merit raises at the end of the year and bonuses if you're fortunate enough to get that stuff. And with that, we'll move into polling question number 3.
This is our last polling question, so just one last reminder to those who are obtaining CPE certificates. You must respond to at least 2/3. So if you did not respond to one of the previous 2, you'll definitely want to respond to this last one. How often do you analyze claims data in order to discover charge capture, clinical, and coding process improvements? Monthly, quarterly, annually, or less often than annually? We don't do this, or not applicable. 80% of you that have voted, so we'll wait just a little longer. Close this poll in another 15 seconds or so. So if you haven't responded and you want to, I would do that now. All right, so we'll close that last question. 51% do this monthly, 16% quarterly, 8% annually or less often than annually, 9% don't do it at all, and for 16% it was not applicable. Micky and Margaret, I will turn it back over to you.
Thank you, Lisa. And then I just put together a slide here really for just some final points to ponder. We have a centralized, where I was previously, of course, at UMC Revenue Integrity Department, but we used a decentralized approach to put that accountability in the revenue generating department's areas, which of course they were a little skeptical of at first, but of course that accountability is key, and they got on board pretty strong after the first year and continue to be successful with their support. Continual training of the staff on the charge processes is a must. That's something I think that gets left out. So that's where we worked with the clinical education departments to have continual training on those processes. Of course, they do evolve over time, and of course your staff, of course, is revolving too in those departments, whether they're moving from department to department or you're getting new, of course, staff coming on. And of course the revenue cycle challenges are increasing, as they are always. Cost initiatives are very important, but they aren't enough, so it's harder to get the money, so be sure you're going after it. You have to have a goal-oriented, I talked about this before, and monitor that performance. That kind of goes back to that business intelligence and those dashboards, revenue cycle dashboards. I always use the example of Lean Six Sigma. I'm sure some of you folks have initiated Lean Six Sigma initiatives, and you've got to be a goal-oriented organization for that to work. You have to be innovative and creative, and I strongly believe that you need technical help. This stuff is difficult. You need comprehensive and compliant charge captures needed to survive. And of course the truth is in the data. I said this before, it's your data, so use it. Use that IT, strengthen your IT to help you query that data, understand it, and look at that return on investment. And of course, do your best and try to have some fun in the process, because this can easily get mundane and frustrating. So celebrate those successes, even those small victories. That's where, again, I think it's key with that ROI, being able to query that, calculate that, take that back to administration, show them how, the importance of the initiatives in the revenue cycle or revenue integrity. And with that, I'll end this presentation and turn it over with questions, unless you have anything else. Oh, unless you have anything to add.
I've got a few.
That's what I was going to say. I didn't forget about you.
Okay. Well, I've got a few concluding points also from my experience at St. Joseph Candler. Micky provides some excellent points to ponder, particularly using that decentralized approach. I found that when I started here, getting the clinical departments involved from the get-go is very important. It makes for buy-in very easy. It also makes continuing education a two-way street, so that you're educating each other. As they're doing procedures that they may not have a charge for, they're coming to ask me, or if I find things that I think they should be charging for, I can go to them. It opens up that dialogue when you're decentralized. And after I've spent some time cleaning up the charge master and getting my feet grounded here, I found that after the cleanup, there's a lot more time to look at the data and then getting to be to focus on those goal-oriented performance indicators. And you do have to be innovative and creative, and you do have to be willing to change and adapt to change, and you do have to have fun. Those are all important also. And with that, I guess we're ready to close out with questions.
Margaret and Mickey, we have one question that came through earlier. Someone requested that you share your CDM maintenance policy. And for anyone else that has questions, if you would like to list those in the chat box on the GoToWebinar, the entire panel should be able to see those, and if not, I can definitely see them and relay them to Mickey and Margaret. So I'll allow you to answer that question and give others time to ask any questions they may have.
So you're talking about sharing an example of a CDM maintenance policy?
I'm not sure. The question just came through and said, can you share your CDM maintenance policy?
I have a maintenance policy that I can share. I don't have it currently available to share now, but I can sure do that after the call.
That, I believe there's another question that just came through that said, I would like an example of the CDM maintenance policy as well.
Okay, that's what I thought they were asking. So yes, we can do that. Margaret?
Okay.
Yes.
I have a question that just came through that asked to explain more what the automated CDM is.
Okay, of course, there's no secret that I'm with Craneware, so we use the ChargeMaster toolkit as the Craneware software to maintain the CDM. And of course, within there, of course, that's where the charges were created. When using that tool, you can have what we call the light view, where the departments can actually submit charges, or if you're in a corporate environment, this could be a corporate and they could submit charges in that get approval in order for charges to get created in the CDM. And then of course there's an interface scripting module that's part of that, and that's where I'm talking about the closed loop, and that's where the charges get created, get scripted over into the patient accounting system so that you're creating them in one central tool, not having to do that in both areas. And of course then it brings in all those regulatory and items that you need in order to create that charge compliantly.
The ChargeMaster toolkit also has a neat function where you're allowed to go back and go back to your requesters and provide information as to where that charge is in the process of being accepted into the hospital billing system. And that is actually linked into your policy and procedure with your approval levels.
Seeing a lot of questions come through in relation to the slides for today. If you look in your GoToWebinar chat box, there is a link there that will take you directly to the presentation slides from today. Mickey, there are several requests for the CDM example. Would it be best for you maybe just to share your email address so that anyone that wanted that can reach out directly to you?
Sure.
Okay.
You want to do that now?
Sure, you can, since I'm not exactly sure what it is without pulling up my email.
That's fine. You can reach me at m.allen@craneware.com.
Another question that came through that says, do you have a reconciliation policy?
Yes.
You want to share a little more about that?
I can share that as well if
Okay.
they'll email me.
Okay. So for those of you that are asking for the CDM maintenance policies, again, if you'll just reach out to Mickey directly, and I'll let him share his email address one more time, he can get that to you.
Okay, it's m.allen@craneware.com. So that's m.allen@craneware.com.
Great, thank you, Mickey.
And I can work with Margaret to get her policies as well and share them both at the same time.
Okay. And again, I'm seeing a few more questions come through about the slides. Those are available in the GoToWebinar chat box, which you should all be able to view. There's a link there in the chat box that you can click on, and that will take you to the slides from today. At this point, I'm not seeing any other questions come through, so we will conclude the webinar. And again, on behalf of the Tennessee HFMA chapter, I want to thank Mickey and Margaret for speaking and all of you for participating. Mickey, Margaret, do you guys have anything else?
Thank you. I do not.
Thank you very much.
Thanks, Margaret.
Thank you, Mickey.
All right. Thank you all.
Have a great day.
Take care, everyone.